Afternoon, everybody. Welcome to the Wednesday afternoon lecture series. I'm Dr. Heather Kimmel from NIDA, and I'm delighted to introduce today's speaker, Dr. Andrew Hyland, a nationally and internationally recognized leader in tobacco control research whose work has significantly advanced our understanding of nicotine use and reduced the burden of tobacco-related diseases. Before we begin, I have two brief announcements. First, the code for continuing medical education credit is 66840. I'll repeat that number. It's 66840. Second, for those of you watching remotely, you may submit questions at any time during the lecture by clicking the Send Live Feedback button below your video cast window. We'll relay the question to the speaker at the end of the lecture. Now, to our guest of honor. Dr. Hyland has more than 30 years of experience in tobacco control research. He has published over 400 scientific papers and has served in advisory roles for the Food and Drug Administration, the Center for Disease Control and Prevention, the National Cancer Institute, and the International Agency for Research on Cancer. He has also previously served as the Deputy Editor of Tobacco Control, the leading international journal in the field. Roswell Park Comprehensive Cancer Center has been Dr. Hyland's home institution throughout his career, where he is currently the Senior Vice President for Population Science and the Robert Ann and Lou Wallace Endowed Chair in Cancer Prevention. His research focuses on generating evidence to reduce the disease burden caused by tobacco as much and as quickly as possible. Dr. Hyland also serves as the scientific leader for the Population Assessment of Tobacco and Health, or PATH study, a major national effort supported by NIDA and the FDA that follows more than 46,000 adults and youth since 2013 to understand tobacco use behaviors and health outcomes. He also co-leads the International Tobacco Control Project, which has conducted surveys in 31 countries to evaluate the impact of tobacco control policies relevant to the United States. His work spans a wide range of topics, including smoking cessation intervention, clean indoor air policy, tobacco product design and packaging, the health effects of different tobacco products, and surveillance of tobacco use in the tobacco industry. His research is frequently used to inform tobacco control policies and public health decision-making. So Dr. Hyland's approach blends research, service, and outreach to maximize community impact and strengthen the evidence base for population-level intervention. So the title of today's lecture is Hiding in Plain Sight, the Opportunity to Dramatically Reduce Cigarette Smoking and Chronic Disease in America. So please join me in welcoming Dr. Andrew Hyland.
Okay, well, I always say you should wait until after you hear what the speaker's going to say, but hopefully we'll get going here. Okay. Again, well, thank you. I'm so excited to be here. I have such great hospitality. Heather Kimmel, you've been a gracious host. Today, I'm here to talk about cigarette smoking, the opportunity to dramatically reduce chronic disease in America. And I'm going to start off, just give you a quick little outline. I'm going to start off with some basics about smoking, highlight its impact on health, highlight some amazing U.S. research infrastructure that's been essential for our understanding about tobacco and health. And then I'll talk about one intervention that could really make a big impact on cigarette smoking and chronic disease in America. Just trying to... Okay, well, I always like to start at the beginning, and this woman is 8 months pregnant with me, and that's my mom. That's my mom. She is celebrating Christmas in 1969. It looks like she's on her third beer, and has an ashtray full of cigarette butts. Back then, people didn't know how harmful cigarette smoking could be. That evidence was just emerging. It was in just a few years earlier, 1964, when that first Surgeon General's report on smoking and health came out that declared smoking to be a cause of lung cancer. But to most everyday people, smoking was still the norm, in part fueled by the massive advertising and promotion budgets by the companies that profited from selling cigarettes. I want you to think about why a person like this, a woman that's 8 months pregnant, would smoke cigarettes every day. So there's no right answer, but I just want you to think about that, and I might put some of my comments later in the talk in context. Okay, so let's start with some of the basics. What is cigarette smoking? Well, first, the question is, what is a cigarette? Cigarette is simply tobacco wrapped in paper. That's it. That's the definition. Cigarettes themselves have about 600 ingredients, and when you burn cigarettes, they produce 7,000 or so chemicals, at least 69 of which are known carcinogens. Cigarette smoking is when you take that roll of tobacco wrapped in paper and you burn it and you inhale that smoke into your lungs. That burning process, that pyrolysis, is where most of the harmful chemicals from cigarette smoke come from. That's a very important takeaway message. When you burn a tobacco product, it creates lots of toxins. Products that don't burn will have lower toxicity profiles. Now, I want to be clear, what I'm not talking about today is vaping and nicotine pouches. I would love to come back another time, share the latest research on what's going on there. We study those things all the time. But briefly, e-cigarettes heat up a solution that's vaporized. It delivers nicotine. Neither nicotine pouches, they're oral. No tobacco in them. Neither product burns tobacco. Each has fewer toxins than cigarettes, but they are not free of toxins. I'm happy to talk with people afterwards about these products, but they're not going to be central to what I'm talking about here. In terms of trends with cigarette smoking in adults, they have been falling year after year after year since peaking in the mid-1960s, right after that first Surgeon General's report came out on tobacco and health in 1964. While things are certainly trending in the right direction, the peak smoking rate was over 40% in those mid-60s. Now it's at 10% of adults 18 and older in the U.S. currently smoke cigarettes. Now, this slide shows the behavior of cigarette smoking, but I do want to point out is that generally there's a long latent period between the exposure to cigarette smoke through cigarette smoking and when the health effects. So there's a lag between when smoking starts and when disease processes begin. So even if smoking rates are low, relatively low, there can still be high levels of disease. How about youth smoking? So rates of youth smoking peaked in the late 1990s above 35% of kids report current cigarette smoking. Since that time, one of the most important public health accomplishments in a very long time has been unfolding. Youth cigarette smoking rates have dropped more than 90% since that time. The smoking rate in middle and high school students now is 1.4%. Cigarette smoking is no longer cool for a generation of young people. Well, who smokes cigarettes today? That's a natural question. Well, looking at it, the highest smoking rates are observed in people who identify as American Indian or Alaska Native, as well as those who identify as Black or African American. Those who are heterosexual generally have lower cigarette smoking rates, and smoking rates are highest in those 45 to 64 years of age, with the lowest rates in those 18 to 24. People with a disability have nearly double the cigarette smoking rates than those without a disability, and smoking rates by educational attainment show stark differences, with an order of magnitude difference in smoking prevalence between those with a GED compared to those with a graduate degree, and about a five-fold difference between those with a high school diploma compared to a graduate degree. Dramatic differences there. That is a collection of, there's 6 items that the CDC uses to define disability, things like hearing loss, trouble with some of the functional day-to-day activities. Okay. So these statistics paint a picture of amazing progress, but there's still a massive public health burden. Cigarette smoking continues to be the leading cause of preventable death and disability and disease in America. Cigarette smoking harms every organ system in the body, as shown on the graphic on the right. It's the tar and the chemicals in the smoke that carry most of the toxins and do the health damage. The nicotine is what causes addiction primarily, but not directly most of the health problems. Rather, nicotine keeps people coming back to that toxic well of cigarette smoke. Experts estimate the annual healthcare costs attributable to cigarette smoking are about $240 billion each year. Now, let's take a look at some of the health impacts with a little more specificity. I'm going to break down the next set of slides into mortality, which are deaths attributable to cigarette smoking, as well as morbidity, and that's about diseases that people get from smoking and live with. The most recent estimates are that 490,000 Americans each and every year die from cigarette smoking. Just 1/4 of these deaths are from heart disease, about 1/4 are from lung cancer, and just under 1/4 is from chronic obstructive pulmonary disease, COPD. Plus, there's a collection of other diseases like stroke and other types of cancers. 490,000 deaths each year attributable to cigarette smoking is about 1 out of every 6 deaths that occur in America. About 1 out of every 5 heart disease deaths is caused by cigarette smoking. About 1 out of 5 cancer deaths is from lung cancer, which cigarette smoking is a predominant cause. So imagine if there was a vaccine that could prevent 20% of heart disease or lung cancer deaths, hypothetically. That would be Nobel Prize material. Any way you look at it, cigarette smoking has a massive impact on mortality in America. But mortality is only telling part of the story. When we talk about morbidity in cigarette smoking, the idea of chronic disease comes up. But what do we mean by chronic disease? So I went to the dictionary, haven't done that in a long time, but according to the Merriam-Webster dictionary, a chronic disease is one that occurs again and again for a long time. It's a medical condition of prolonged duration. So that's a good start, but are there other defining features? And there's been some work done on this, and on the right panel is some information extracted from a paper a few years ago trying to add a little bit more clarity on this. So some of these other elements include a disease that can't be prevented by vaccines or cured by treatment, diseases that don't disappear, diseases that are associated with functional impairment. That makes sense. It's not just having some condition, but there should be a negative health consequence in order for it to be a chronic disease. So some example conditions include things like arthritis, asthma, cancer, diabetes. The potential scope of chronic disease in America can be vast. But we're interested in the amount of chronic disease that's caused by cigarette smoking. And surprisingly, there's not like a ton of literature. There's some, but there's not a ton of literature when we're looking at comorbid conditions. What turns out to be one of the early papers on the issue is one that I led some 25 years ago that used national surveys to estimate attributable fractions for a few conditions. So the epidemiologists out there would have a sense of what that is. The Surgeon General updated that analysis about 10 years later. So in addition to that, I did some recent digging, and here's a summary. This is my own summary. This is not part of a rigorous lit review or a meta-analysis or anything, but the conditions above that thick horizontal line, these are things that the Surgeon General has reviewed and declared to be caused by cigarette smoking. So these have a high threshold of evidence. And below that line, an example condition, dementia, is listed. It's not yet made it on the Surgeon General's list, but there's accumulating supporting evidence that cigarette smoking is a cause of dementia. And some groups, like the World Health Organization, have already made that conclusion. So the columns on the table, they give some estimates compiled from the literature about the scope of each condition and how much is attributable, estimates according to these studies, how much is attributable to cigarette smoking. So there's an estimated 20 million or so Americans alive with heart disease, lung cancer, or COPD that's caused by cigarette smoking, with an estimated $60 billion annual cost in health attributable to smoking. But other conditions that we don't think about so much as being caused by smoking have significant attributable disease burden. So about 10% of type 2 diabetes is attributable to cigarette smoking. It's with a massive $30 billion estimated annual attributable cost. However you slice it, cigarette smoking is a significant factor in a wide range of chronic conditions that affect millions of Americans, resulting in billions of dollars in added healthcare expenditures. Now, the points that I want you to take away from this first part of the talk are here, and really the summary takeaway is that millions of people have chronic costly conditions caused by cigarette smoking. With swift reductions in cigarette smoking, most chronic lung disease could be eliminated. Major declines in rheumatoid arthritis and age-related macular degeneration would be experienced, and large absolute numbers of reductions in fewer cancers and fewer heart disease cases could be achieved. Well, of course, swiftly reducing cigarette smoking. How do you do that? That's a tough question. Certainly one approach is to increase the number of people who try to quit, and the other is among those who do try to quit, how do you maximize the likelihood that they will stop smoking completely for good? So let's take a quick look at what the science tells us about the benefits of discontinuing smoking. There was a landmark paper from a 50-year prospective cohort study of British doctors that estimates discontinuing smoking by the age of 40 reduces almost all of the excess risk of dying prematurely from cigarette smoking. Quitting beyond the age of 40, at any age thereafter, adds to life expectancy. So even quitting at 80 years of age adds to life expectancy. It's never too late to quit. And stopping earlier produces more health gains. The infographic on the right shows that even after 20 minutes, heart rate and blood pressure begin to normalize. Within weeks, circulation and lung function improve. After about a year, the risk of coronary heart disease decreases. And after 15 years, about 15 years, the risk of heart disease is about the same as somebody who's never smoked cigarettes. Now, of course, preventing young people from starting smoking also has a huge impact, and those benefits are realized over time in an accelerating manner. The dramatically lower youth smoking rates achieved in the last 30 years are now paying dividends, with those kids who did not start smoking 30 years ago getting fewer heart attacks and fewer cancers. Helping people quit smoking and preventing people from starting smoking is a 1-2 knockout punch for chronic disease in America. In addition to the health effects, research shows that reducing cigarette smoking is a big opportunity for reducing healthcare expenditures. This study estimates for a relative 10% change in cigarette smoking prevalence is associated with a 1% change in healthcare expenditures. In 2012, they estimate that would amount to about $60 billion each year. Now I'm going to pivot just a bit and ask this question. How do we know these things about the cigarette smoking, mortality, morbidity, that smoking causes these things? Well, it's research. It's science. And that science would not be possible without the U.S. taxpayer investment in scientific infrastructure. That infrastructure provides unparalleled tools for insight into these key factors that impact the health of all Americans. Research matters. Now I want to talk about two of the crown jewels of the tobacco research that have been supported by the U.S. National Institutes of Health. The first is the Population Assessment of Tobacco and Health Study, and the other is the International Tobacco Control Project. Okay. Well, the Population Assessment of Tobacco and Health Study, or PATH study, well, that's my ticket here. Heather talked about it, And I appreciate that, Heather, and it's been great working with you on this. The simplest way I can describe the PATH study is how somebody expressed it to me many years ago. The PATH study is like the Framingham study, but for tobacco. Now, of course, the Framingham study was designed to answer key questions about heart disease, the leading cause of death in America. And to do this, they went to the small town of Framingham, Massachusetts, and invited all the residents to participate in what turned out to be a decades-long prospective study, which continues to this day, on the causes and outcomes of heart disease. The PATH study does not yet have that same longevity, but we are 15 years and counting into the mix, and it's providing the foundation for the scientific understanding of tobacco products, behavior, health endpoints in this current evolving tobacco marketplace. The PATH study is a partnership between the Center for Tobacco Products within the FDA and funder, where Nicolette Borick is the study lead, and the National Institute on Drug Abuse, and contract administrator, where Heather Kimmel is the study lead, as well as collaborations with many other federal agencies, is shown on the slide, and many of you are here today in the organizations that you represent. Westat holds the contract to implement the study under the direction of Charles Carusi, and I am the scientific principal investigator of the study from Roswell Park Comprehensive Cancer Center. Now, let's take a quick look at some of the key features of the PATH study as noted on NIDA's website. The PATH study has been in the field continuously since the first wave was launched in 2013. We've been tracking participants over time and replenishing the sample periodically. 12 sets of data collection are complete. Youth and young adult data just wrapped up collection a few weeks ago, and future data collection efforts are being planned. We ask about tobacco use, health conditions, a wide range of contextual factors to understand how these endpoints might be connected with each other. The PATH study does among the most comprehensive job at assessing the wide range of tobacco products used, ranging from cigarettes to vaping products, nicotine pouches, different types of cigars, and more. The other point that differentiates the PATH study from other efforts is that it's nationally representative and longitudinal, which is a powerful design for teasing out cause and effect. Wave 1 sample size is about 45,000 people, including about 13,000 youth, aged 12 to 17 years of age, and about 32,000 adults, 18 and older. These sample sizes have generally persisted in that kind of ballpark. There is some variation. There's new replenishment that comes in. Of course, there's attrition that happens. There are some special collections that have been adopted periodically throughout the study. Of course, COVID pushed us to adapt in many ways to maintain data collection and continuity. And I am proud of the more than 1,000 PATH study-related papers that have been published by the research community from this amazing resource. Many of these papers are in high-impact journals that are challenging paradigms, informing practice, and informing policy. So with more than 1,000 papers and counting, it's hard to pick the most significant research, but I'm going to make a stab at some of this, where some of the unique and lasting contributions. The first item that I want to point out is about poly tobacco use. This is using more than one tobacco product. Historically, people used to just use cigarettes. You didn't really have to worry about people using more than one product. But 10 or 15 years ago, things began to change. And PATH study data early on estimated that about 40% of both adults and kids who use a tobacco product are actually using 2 or more tobacco products. This opens up a whole new line of thinking about how to address tobacco use. Which product is predominantly used? Why are people using multiple products? So take vaping, for example. Some people report vaping in an effort to get off of cigarettes completely, while other people report vaping and smoking as a reason to keep smoking cigarettes, using vaping products in times or in places when they can't smoke cigarettes. Very different patterns of use, very different health endpoints. The PATH study is helping to set the standard for how these are measured and understanding what the impact of these different trajectories are. With a more diverse tobacco product marketplace, lots of products that people are using. A natural question is if some products have different or greater or lesser exposures than other products. The PATH study, through its biomarker collections, have identified high levels of biomarkers of exposure to toxins, which is driven by cigarette smoking. If you smoke cigarettes, your biomarker levels are high. If you don't smoke cigarettes, your biomarker levels will be lower, perhaps not quite as low as not using any tobacco product, but generally lower than for people who smoke cigarettes. And even people who smoke cigarettes and add vaping to it as an aggregate group, we see that their biomarker levels are very comparable to those who only smoke cigarettes. So the idea that you could smoke cigarettes and add vaping to that in order to reduce your exposures is called into question by these PATH study biomarker data. The last example that I'll highlight is that the relationship between smoking and vaping is incredibly complex. As I noted before, many people say they vape in order to get off cigarettes, but many other people say they vape for reasons that are not health-related. And of course, many young people who've never used any tobacco product are vaping, and there's only downside risk to young people who are vaping. The literature from the PATH study, in the past, we've looked at this, and other groups have looked at this, on whether vaping helps people quit smoking, seems to be evolving over time. Several years ago, the PATH study data did not show much of a relationship between people who smoke cigarettes, some of them vape, some of them don't. Their quit rates were about the same. But more recent data with vaping products used since around 2017 or so, show a divergence. And since that time, people who smoke and take up vaping seem to have higher rates of quitting smoking, discontinuing smoking completely, compared to those who did not take up vaping. This is consistent with a recent Cochrane review on the clinical trial evidence that concludes with high certainty that e-cigarettes with nicotine increase cigarette quit rates. So this is a complex, dynamic, and super important issue for chronic disease management, especially if these relationships are changing over time. You don't see that a lot of times in science. You find a mechanism, well, that mechanism is what's there. It's not ever changing. Here, maybe we're seeing a difference as the products in the marketplace and as what the companies are promoting are changing. Really interesting PATH study data in the field to allow us to address some of these questions. Okay, so for the curious out there, it's an amazing resource, longitudinal 12 ways of data collection. If you're interested in this, there's all kinds of questions on here. Most of them are tobacco related, but there are some items that are contextual that maybe go in additional areas. If you're curious, I ask you to spend 1 hour, take 1 hour of your time, go to the QR code. This will take you to the data archive page at the National Addiction and Data Archive, and all the PATH study materials are there, all the questionnaires, all the details. Check it out, and if there's something in there that's like, wow, that would be super cool, I bet Heather Kimmel would love to hear from you. There are relationships with a number of the NIH agencies working in partnership on there. Lots of opportunity and lots of avenues to go through. At the National Addiction and HIV Data Archive, there's the restricted use files. I think Dr. Conway just put an application in. Seamless, not so bad, right? And there are public use files. There are some basic data tables that give you the basics, and of course all the questionnaires and training materials, which are wildly popular and really help get people set up in the right direction. Okay, so how do we know these things? This is where I want to pivot to the second data source that's contributed so much to our understanding of the impact of tobacco use, patterns, and interventions to address tobacco use. So this is the International Tobacco Control Policy Evaluation Project, or ITC project for short. I'm MPI of a PO1 that supports, in part, the ITC research initiative. The ITC project aims to examine variation internationally on how different products and policies affect tobacco use. So all these quasi-experiments are happening in other countries. And our goal is to study what happens there and try to understand and bring that back here into the U.S. to try to allow us to predict what might happen if a certain regulation or if a certain educational initiative or intervention were implemented. The ITC project has been ongoing since 2002. It includes data from 31 countries. And in fact, the ITC framework has informed the PATH study design and has helped the U.S. learn from the experience elsewhere. Some examples of questions that the ITC project has investigated in great detail are things like graphic warning label on cigarette packs, advertising restrictions, smoke-free policies, pricing strategies, effective new medications, new products, heated tobacco products. We're in Japan and Korea, for example, where heated tobacco products are quite common. Nicotine pouches, vaping products were one of the early adopters that we started looking at, as well as some mechanistic things about how and the quitting process that people have. So the idea that the U.S. could benefit from the experience of other countries is not new. And in fact, just this December, the President's office issued this fact sheet with respect to childhood vaccination. But I'll quote where I can quote, highlighting the fact sheet directs the Secretary of Health and Human Services to review best practices from peer developed countries for vaccination recommendations. And if the Secretary determines those practices are superior to current practices, then they're directed to update U.S. policy to align with such scientific evidence and practices from peer developed countries. Now, of course, every research topic is different, and I'm not here to talk about childhood vaccination, but the point is that this sets the precedent of looking to other countries to help inform the experience in the U.S. And of course, and I'll state the obvious, that decisions made by regulators are made by the regulators in the administration, and they are uniquely positioned to identify the success, what those successful practices are and which ones are best aligned with administration priorities. So I want to give a quick recap before we pivot to the next section. A recap: burning cigarettes. If there's one thing to remember, if you burn something, the toxin levels are high. Cigarette smoking has fallen sharply, but progress is uneven. Cigarette smoking is the cause of millions of chronic diseases in America. Dramatically lowering cigarette smoking will yield health and financial savings. The U.S. investment in research and surveillance allows for this understanding, and two terrific example projects are the PATH study and the ITC project. Okay, so we're level set, but this was supposed to be a talk about something hiding in plain sight for some dramatic opportunity. So what is that dramatic opportunity? And I'll pivot into the last section of the talk. And that opportunity is right here. It's a proposed product standard that would reduce the levels of nicotine in cigarettes so they would not be addictive to most people. This idea was first put on the Center for Tobacco Products consideration list several years ago. I think it was 2017. Then it was removed and brought back. And this proposed rule is currently still open. The public comment period is closed, and the agency, the FDA, is reviewing the vast amount of comments and deciding what the appropriate next course of action or inaction is. Now, I want to take a moment to talk about nicotine addiction. When someone administers nicotine, especially smoked nicotine, it goes right to the lungs and then right to the brain. You feel it right away. And those nicotine effects, they start a whole cascade of chemical processes. One is that the feel-good receptors in your brain are stimulated. But after a little bit, that nicotine is metabolized and those effects begin to go away. The process of addiction is when your body craves those initial sensations. So basically, when that nicotine goes away, your brain screams, "I want more, I want more." And the individual experiences nicotine cravings that are uncomfortable. Readministering nicotine makes those cravings go away and lights up those dopamine receptors. It's this circle that grows to become addiction and makes it hard to simply choose to stop smoking or to stop using nicotine. But then there was this bold idea. What if cigarettes didn't have so much nicotine, so they weren't addictive? Neil Benowitz and Jack Henningfeld first proposed this in a piece in the New England Journal of Medicine 32 years ago. They suggested the idea of a threshold nicotine as a way to avert addiction. They suggested that this should be investigated for a possible regulatory approach. Former FDA Commissioner Scott Gottlieb and former Center for Tobacco Products Director Mitch Zeller wrote a follow-up piece in 2017 that outlined what a reduced cigarette nicotine standard might look like in today's regulatory setting. Now, understanding the Center for Tobacco Products didn't exist in 1994. That only came into being in 2009. So in this new world, what would that look like where FDA has regulatory authority over tobacco products? They noted that reducing cigarettes' addictiveness could help addicted users, their words, addicted users, quit more easily and help those who are experimenting, young people in particular, from progressing to regular smoking. They pointed out the potential public health benefits, and ultimately, they may be able to transform the tobacco marketplace and delivery of nicotine to protect future generations of young people and save millions of lives. Mr. Zeller wrote about this idea of tobacco products being on a continuum of harm, as broadly demonstrated by the cartoon on this slide. On one side are the combustible tobacco products that have the highest exposures and likely greatest harms, and on the other side are products that have the lowest exposures, like medicinal nicotine, nicotine patches, things that go through the cedar route for authorization as drugs. These products then there are products in the middle that we know less about the relative ordering, but as Mr. Zeller notes, that things like vaping products or smokeless tobacco are probably in the middle somewhere. When Mr. Zeller became Center Director, he directed his agency to review the evidence on the reduced cigarette nicotine approach. And in January 2025, under a new Center for Tobacco Product leader, a proposed rule was issued for public comment. This rule, it focused on reducing the levels of nicotine in cigarettes and other combusted tobacco products, but not in e-cigarettes or smokeless tobacco products. And I want to get into a little bit of some of that science of the basis for this. This landmark study led by Eric Donnie and Dorothy Hatsukami provided the empirical evidence for reduced cigarette nicotine standard. And what they showed is it could reduce nicotine dependence and the number of cigarettes smoked. I want to take a look at this in a little bit more detail. What they did in this study is they identified 7 groups of about 120 people per group. These are people that had no intention of quitting in the near future. And they assigned them to their usual brand and then to some varying levels of lower nicotine brands. Actually, the nicotine levels varied by 2 orders of magnitude. And assessments were made at baseline and then through 6 weeks of the intervention. Looking at the endpoints of changes in cigarette consumption, 2 clear groups emerged. Cigarettes with 2.4 milligrams of nicotine per gram of tobacco had significantly lower or fewer cigarettes smoked than those who had higher nicotine brands. Going a step further, when they measured levels of nicotine dependence, it was only those in the groups that smoked even lower nicotine level brands that had significantly lower levels of nicotine dependence, brands with 1.3 milligrams of nicotine per gram of tobacco. And going a step further, it was only those who smoked the lowest level nicotine brand of 0.4 milligrams of nicotine per gram of tobacco that had significantly higher rates of trying to quit smoking. Remember, these people, none of them planned to quit smoking, but some of them going through the intervention decided that that was the right thing to do. In addition, the investigators did not see what many people were worried about was a compensation, that people would smoke more. If you reduce the nicotine in cigarettes, maybe people will just smoke twice as much. But if that would happen, you would see that, like that first week, you would see a big spike up, and then it would come down. So that compensation piece was not experienced. And this initial landmark trial led to a whole series of additional trials in their lab, as well as by other investigators, that replicated these findings in wide-ranging populations and conditions, from young people, people with mental health conditions, people of different races, ethnicities, and socioeconomic statuses. Now, another practical consideration is if a policy like this should be implemented all at once, or if it should be gradually phased in. And the Hatsukami lab took a look at this. They designed a study to do just this. And what she and her team found is that the immediate cigarette nicotine reduction group had significantly reduced numbers of cigarettes smoked and more days abstinent at 20 weeks than the gradual nicotine reduction arm. However, there's always a however in there. The immediate reduction arm was associated with greater withdrawal symptoms for about 1 month, and they had higher study dropout rates, and they also had higher non-compliance with the study cigarettes. That means people were going to the store to buy the cigarettes with nicotine in there because their study cigarettes weren't giving them what they wanted because they had higher withdrawal symptoms. So taken together, these findings suggest that people who smoke may seek out other sources of nicotine if the cigarette nicotine reduction policy is implemented quickly. Now, how much of an impact could a policy like this have? And so the Center for Tobacco Products commissioned an expert review a few years ago. It's since been updated. These are some snippets from that initial New England Journal of Medicine paper. The takeaway is that the authors estimate that a regulation that reduced cigarette nicotine levels to very low levels would prevent millions of kids from starting smoking with benefits that increase over time, and that translates into millions of premature deaths averted, tens of millions of life years gained, and these health benefits accelerate over time. So it's easy to get lost in the numbers. I want to restate that again. A very low cigarette nicotine policy will prevent millions of premature deaths and add tens of millions of life years to the American population. Some strategies to consider if a cigarette nicotine reduction policy were implemented as you're thinking about the implementation, because the science is important, but the implementation can be equally important. There should be smoking cessation support, free support, widespread support. There should be public education to educate people about the policy. There should be continued innovation for better treatments. There should be measures to try to minimize illicit markets for conventional cigarettes with full nicotine. So here's where things are. The proposed rule for reduced cigarette nicotine standard, that public comment period is closed. FDA is reviewing comments and considering what their next actions. Those next actions could be any of the following here. They could issue a final rule and implement the policy today. That could happen. There could be a signature and that policy could get implemented. They could modify the rule and repropose it and get public comment on that. They could withdraw the rule, or they can continue to deliberate, and there's no fixed timeline for issuing, modifying, or withdrawing that rule. So regardless of the FDA course of action, the science tells us that reducing nicotine levels in cigarettes so they are not addictive to most people will have a huge impact on reducing the disease burden in cigarette smoking in America. And we know this from the U.S. investments in high-quality research, research infrastructure, and learning from the international experience. Okay, so my last slide, I want to express my appreciation. The National Institute of Health, the largest supporter of biomedical research in the world, to research participants in all studies who volunteer their time and commitment for science. I especially want to thank Dorothy Hatsukami from the University of Minnesota and Tracy Smith from the Medical University of South Carolina, who helped with some of the content for these slides. And I want to thank NIDA, FDA, and the PATH study team, as well as all my colleagues at the ITC project team. All right. What questions are there? Thank you.
Okay. Thank you. There are mics if people want to use them. I do have some questions on mine to get started as you're walking over there. One just coming about what you were just talking about. See, what is the natural amount of nicotine in tobacco? Is this nicotine policy indicative that cigarettes have unnatural levels? Have they been bred, as I heard, to have more nicotine, and how can you just remove it?
Great question. I think the usual brand of nicotine was something like 1 point something milligrams per gram of tobacco. I think that's like in the ballpark. And there's some difference between what's in the actual tobacco and what's delivered to the user when you burn it. So it's a little bit more complex. But on average, you're looking at about 1 milligram of nicotine delivered to the user under usual circumstances. Manufacturers do have the ability to vary nicotine levels, and they have different strategies for doing that. I don't know if I would characterize them as, I would characterize them as manufacturing processes, just like there are different levels of alcohol in different sorts of drinks, or different levels of sodium and different sorts of components. There are different sorts of manufacturing processes that could be done. Who else?
Well, thank you very much, Dr. Hyland. That was wonderful. One bit of background that I think is pretty remarkable is that those studies of reduced nicotine actually required an unusual degree of infrastructure, in that the National Institute on Drug Abuse, a little bit with partnership of the FDA, but mostly on our own, had to actually become a cigarette purchaser. We had to issue contracts to develop and then distribute tobacco products with different levels of nicotine in them to allow those studies to be conducted, which was a little bit of an unusual enterprise that surprised many of us, but proved to be a really important element of the success of those studies. I have a question for you, though, about the potential impact of the nicotine reduction. Any estimate of how many will actually quit tobacco completely versus shift to other nicotine delivery, and any thoughts about how we push for the healthiest nicotine delivery for those that still require nicotine after it's no longer available in their combusted products?
Yeah, great question. You get right to the tricky part, I think, there, Wilson. I think the specifics, I don't have the numbers in front of me, but in that Ben Appleberg paper that I cited, and then that's been since updated, there are estimates of the fraction that would quit with such a policy. In the more recent times, it's a little bit more complicated, because some people will quit all tobacco products, some people will switch to a vaping product, now a nicotine pouch product, and who knows, there might be other sorts of substitutes that even fall outside of nicotine, like cannabis legalization opens up possibilities. There's some studies that show cannabis and nicotine can be substitutes for each other. So there's still more to learn there. And I think where you're going is that the idea of somebody switching and taking up vaping maybe has a different health trajectory than somebody who stops using cigarettes and doesn't use any other tobacco product. And that's where there's opportunity to really try to understand what those physical health harms are. And I know that in the discussions I'm in, there's different view of addiction itself, for many people, is a health hazard, regardless of anything else. For others, it's if they're addicted and they're not getting lung cancer, then do we need to be worried about that? So those are elements where data can provide the science on that. Generally, you're talking about with vaping, you're talking about younger people, and getting vaping daily, using nicotine pouch. In those circumstances, nobody thinks that young people using nicotine products and getting hooked on them is a good idea. And
Thank you.
I
would point out that implicit in what you've described is how the tobacco marketplace has shifted so much in the last 20 or 25 years in the U.S. And that's a change for tobacco researchers from considering it sort of static. It's not so unusual in those of us working in the illegal, illicit drug research community, where we're very used to things changing every few months or every years and have to maintain a thoughtful surveillance program. But thank you very much.
Yeah, and Wilson, as a follow-up, the vector, that component, the supply side, the industry as a vector for linking up the product, those exposures to the individuals, and that is an opportunity, I think, that's been relatively understudied. And in an environment where the products themselves are changing, you need to understand those factors. So thank you. Yeah, Kevin?
Thanks. I'm sure you're aware of the association between GLP-1 agonists and changes in weight, and also in addictive behaviors, potentially alcohol, other substances, and possibly tobacco. So there's growing evidence for this as a potential opportunity. I'm wondering how the GLP-1 agonists have entered your mind as an additional, maybe unexpected opportunity for public health.
Absolutely. Yeah. the opportunity is there. PATH study, for example, is a national longitudinal cohort. So there are opportunities to study questions like that.
Are there such items in the survey?
I'd have to check on that.
Okay.
Okay. I had a couple questions that are related. I'll try to combine them. Essentially, is there any country that's doing particularly well in reducing smoking rates, and could that work here? And it's another little twist to this. Is there? No, that's it. Yeah. Is any other country doing
Other
well?
country? This comes up a lot. A lot of times Sweden is used as an experience of what's worked, of like where Sweden has adopted snus, which is a type of smokeless tobacco product in 30 or more years ago. Other parts of Europe, snus is illegal. Lung cancer rates in Sweden are the lowest in Europe, and many people cite that as a reason why endorsing a more of a harm reduction approach is beneficial. There are other countries, though, that have taken different approaches that maybe not quite the same as Sweden, but Sweden's had a longer runway. I've taken a look at some countries like Japan, which has seen huge transitions, cigarette smoking, with their heated tobacco products that have been in the market. Huge difference. That's often cited. But you know what? Those changes in smoking in the U.S. are almost exactly the same percent decrease in per capita consumption as experienced in some of these other countries. So I would say, this is maybe going out there a little bit, so maybe an opinion, that the strategy that's most effective is the strategy that can get implemented in a location, in a jurisdiction. And those strategies could include things that lean more toward a harm reduction approach, but they could also lean into more like a youth prevention sort of approach, but there would need to be a commitment for the public education and the supporting policy sorts of initiatives in there. So, tricky question. Yeah. Calvin.
Dr. Hyland, thank you for coming and for your very informative presentation. In addition to the answer that you mentioned, I think Australia and New Zealand have done very good work in their tobacco control and have actually, see dramatic decrease in the cigarette consumption way before the U.S. does. Two questions. One, you mentioned about, and you spent quite a bit of time talking about reduced nicotine cigarettes and the potential health impact of the regulatory action. Have there been studies looking at, because you also mentioned American Indian, Alaska Native, and people of low income also a higher prevalence of cigarette smoking. Have there been studies looking at those particular population, how they respond when there's like available of low nicotine cigarettes, and do they perform or behave the same way as the general population?
And these are some of the populations that have higher cigarette smoking rates.
Right.
I noted at least some of those are my understanding, and that was the one side is just qualitative, but lower SES, I think, across some diversity in race ethnic categories, self-identification, and mental health, I think, was another area. So there's pockets of studies looking at some of those individual populations demonstrating similar kinds of effects of a reduced cigarette nicotine standard as was observed in the aggregate group.
All right, thank you. The second question, this is more of a meta science question. So, as we know, tobacco industry internal documents told us that they also conduct studies, and largely in the purpose of confusing the public about the harm of cigarette smoking, secondhand smoke, and so forth and so on. Now, these studies, however, many of them still remain in circulation in peer-reviewed journals and published after peer review. So how do we, with that knowledge now, how do we avoid coming to erroneous conclusion while those data are still out there?
Mm-hmm. Well, I would love to, get a group of people together and, trying to think through these elements that are there, that's, yeah.
Thank you.
Thanks.
Okay, over here.
I have a question that's sort of similar to the question about Europe, but sort of on the other end. A lot of like Western European countries especially have put in more restrictions in place or more obvious warnings about smoking.
Yep.
Like literally just on the package, this causes cancer. But they've seen less decrease in smoking. I was wondering if you had an idea as to why.
These issues, they're multifactorial. So the graphic health warning, most countries now have graphic health warnings, images, pictures, big words, lots of the real estate of the pack devoted to trying to educate people about the dangers of cigarette smoking. But it's just one of multiple interventions. In the public health strategy, you've got pricing strategies, you've got public education, you've got long history of social norms where things are tricky. Canada was the first country to adopt graphic health warning. The evidence is very strong that those warning labels work. The evidence is also very strong that they wear out over time and they need to be boosted with new images, new content, so you get this fade. And in fact, we have a paper, an abstract at SRNT this year that reviews all of the ITC data, all 31 countries, multiple waves, more than 100 waves of data, all focused on the compilation of evidence on the graphic, on health warnings and the factors associated with what works. So I think that the science on the graphic warning labels is clear. It's just that there are other factors that are there, multifactorial, and then intersecting in with industry factors. Like even like the industry, they set the pricing by and large for the products. I'm a big proponent that price is a big driver of things. And when there are pricing, when the industry controls how the products are promoted and what the pricing strategies are, even if there's high tax rates, that those levels can be kind of mitigated based on the industry component. So the short answer is that it's a multifactorial with multiple agents, both public health agencies, but also the industry side, which is ultimately trying to maximize profits. But along with that kind of comes increasing things that are going to increase use, but not always so. But the pricing strategies are one that I'll offer.
All right, thank you.
Okay, maybe one more question online here. Again, a summary of people were asking about this vaping duality, harm reduction, but also harm introduction, especially to a new generation. Mike, for example, straight out asked, would you advocate for current smokers to switch to lower risk non-combustible tobacco products?
Mm-hmm. So, yeah, complex, but these are the issues of the day. So that's why this is important, why the science is important, why the infrastructure is important. I think that the Center for Tobacco Products and the approach that they are taking with the product authorizations, so they have a regulatory process for things to get authorized, either pre-market authorization, and I think that they are striking a strong middle ground where their position is not using any tobacco product is preferred. Getting off of cigarettes is a priority. The front line should be using FDA-approved stop smoking medications, nicotine patch, nicotine gum, bupropion, and others. If that's not successful, then talk with your healthcare provider about lower exposure products, which could include vaping products, and looking through there. And if you do use vaping products, don't use them for too long. Get off of cigarettes and then look to transition away. And in terms of a middle ground, I think a lot of people can get behind that, but it's complex. And there's multiple perspectives, multiple issues, but I think that I would encourage people to check out the Center for Tobacco Products position, how they approach it. I think strikes a balanced middle ground.
Got it. Dr. Kimmel, you any closing remarks? And there's going to be a reception. You can.
Oh, is there? There's if there's time, I don't know if there's.
Oh, sorry. Yeah, one last question. I was just curious if there's any sex differences in how people respond to the low dose nicotine in terms of their smoking behaviors, and then also thinking about for reducing the addictive potential for youth, who will go on to smoke. Yeah, is there any evidence of like a sex-based difference in reducing addictive potential in the low dose?
Great question that I don't know the answer to.
Okay.
So I will take a look. I encourage you to take a look. I know there have been studies that have, I bet that's been looked at, but I don't know the answer to that. I've not heard that being an issue, an argument against a policy like this, so my presumption is that they're broadly comparable, but there is evidence that there are sex differences in response to other stop smoking medications, so it's plausible.
Yeah,
Could be.
yeah, maybe some of that makes sense why the very low dose is the most efficacious one. Okay, thank you.
Thank you.
Okay. Well, thank you so much, Dr. Hyland, for your very interesting talk and very informative. We really appreciate your insight. And I encourage all of you, and those of you online and in the room, to contact Andy with any questions that you might have after this presentation. And thank you all for your time today. We really appreciated you. And thank you very much. Have a wonderful afternoon. And we have a reception up in the lifted auditorium area after this. So please join us for that for a few minutes. Thank you so much. Have a wonderful rest of your day.